One more question I had. You said, I think Sir also said, males were predominant, females. Now it's become equal. What's the reason for that?
Center it's still male predominant only, sir.
In St. John's.
And I also feel the increased testing. So that has kind of changed the stats of it. The testing is good and people are more aware. The stigma is kind of reducing. So I think those are the reasons for even females coming out and the spouse counseling. So most of it we see are spouses of the individuals testing positive. And they come quite late actually. I think these are the reasons I could think of.
Okay, then thank you, Dr. Priyanka, for that informative talk. Now I request Dr. Rita Prakash to come on the dais and honor Dr. Priyanka. Come, Dr. Harish. Here. Really colorful. Yeah. Thank you, Dr. Priyanka. Thank you, Dr. Rita. And I now call upon Dr. Ravindran to come back for another 10 minutes. Is it 20 minutes? Okay, 20 minutes because it's an important topic. Just bear for some more time because this is almost most of us have forgotten about HIV. In fact, there is one thing. So just take on that. And I request you to speak on the new two products also, which have been shown.
Which one?
These Spectra,
She spoke.
Spectra and
She spoke.
yeah, she spoke about
Yeah,
that.
Noltagaviran.
They didn't give much focus. One-time tablet for 30 days, 90 days. Something is mentioned there. Can you please?
Yeah, I'll come when I talk
please.
about it.
Thank you.
Okay. Thank you. Can I have the next slide, please? Now, when we talk about prevention of HIV in 2020, before 2020, we have talked always about ABC, abstinence, being faithful to your partner, condom use. Now we talk about different things because of their development in science. Early use of ART and suppression of viral load. This came out in 2011. And since then, it has become the standard of care that we should suppress every patient of HIV with antiretroviral therapy. And antiretroviral therapy has to be started on the day you diagnose HIV infection, usually within the first 2 weeks. That is the standard of care. Previously, we used to wait for the CD4 count to come down. The CD4 count fell less than 250 or 500, we would start. But now CD4 does not matter. All that you need is to start the patient if his HIV test is positive and viral load is positive. Then in 2015, we found there was a post-exposure prophylaxis. A meta-analysis showed that it's very effective, 95% prevention. Then in pre-exposure prophylaxis, that is even before the person has sex, here there in 2012, showed it prevents again about 95% prevention of HIV transmission. Mother to child transmission was the oldest one, which talked about prevention using drugs. That happened in 1994. Next slide, please. Now, when we talk about this case, Mr. K is on ART medication. He is married and practices safe sex with his wife. He discovers that the condom has broken during sex. The couple contact you. What will you do? Anand? Anybody would like to say any answer this question? Pardon? No, he is already HIV positive. He is on antiretroviral therapy. Okay. And now he says, and the wife is negative. Now the condom has broken during sex.
That will treat us as an exposure and give exposure prophylaxis.
Exposure prophylaxis. Anything else?
And testing as well.
Testing. Okay.
Of course, as was told by ma'am, first is initially, as well as even after a month and after 6 months. I guess that was the post-exposure prophylaxis testing.
Okay.
Yeah.
Okay. Anybody else would like to add? Okay. Can I have the next slide, please? The questions that we need to answer is, what are the chances of developing HIV after a single unprotected sex? It's one time that they had sex without protection. What are the chances that the lady will infect? The second thing is, what are the chances that the husband, Mr. K, can transmit infection to his wife, then what PEP can be offered to them? What tests will identify the infection early? These are the questions that people usually have. Now, coming to the first question, next slide, please. What are the chances of getting in this unprotected insertive penile vaginal intercourse? The chances of getting infection is very, very low. It is 4 per 10,000 sexual acts. It's a very, very low. But when it keeps repeated, it goes into geometric proportion and you get infected. So the chances of person getting infected with a single unprotected sex is low. Okay. The second point is, can the husband transmit the disease? Next slide, please. If the virus is suppressed, the chances of some transmission to another person after 6 months of antiretroviral therapy becomes 0. Okay, that is why we coined the term U equals U. Undetected is equal to untransmissible. So the chances of this lady getting a HIV infection is almost 0. And if you want to be more sure that she's not having HIV infection, next thing that you do is a post-exposure prophylaxis. Next slide, please. I'm talking about backbone regimen. We talked about tenofovir, lamivudine. Okay, now we have dolutegravir. You give dolutegravir also to these patients. And usually what we do is once we give these drugs, we treat them for 28 days. Why 28 days? Because studies in animals have shown 28 days gives protection against sexual transmission. We cannot obviously do a randomized control trial because it's not ethical. Saying half the people are on drugs, other half not on drugs. You cannot do that. So that is the reason why 28 days has been recommended as post-exposure prophylaxis. And when do we test the patients? We test them immediately 3 weeks later, 6 weeks later, 12 weeks later, and end of 6 months after this exposure. Why do we test immediately? Next slide, please. Next slide, please. No. I want you to look at this figure. Immediately, for the test to become positive, it takes at least 3 weeks. Before that, the test is negative. And whatever we do, we cannot detect the infection within 5 days. If this is the science, why do we test immediately? Because we want to be sure that this lady has got the infection from this exposure. She should be HIV negative and then she should seroconvert. Then you know that this person is likely to have acquired the infection from this sexual encounter. Okay, and can you go to the previous slide? And usually test that, no, next one. Next slide, please. And usually it takes ELISA test to be positive, it takes 6 to 8 days after exposure. So the first 6 days, no test will help you to identify these patients. You will get this. Now, people, I've given a family situation, but you will come across people who have experimented, have a broken condom. Next day, they're worried. They want to know whether they're infected or not infected. So remember that 6 to 8 days, all your tests will be negative on these patients. Okay, next slide, please. And you do only HIV ELISA tests for diagnosis. This is a standard regimen. You do not do Western blots. You do not do viral loads. Okay, because they are not helped for diagnosis. Diagnosis is based only on doing ELISA tests. Okay, next slide, please. And when we talk about ELISA, depending upon what is the situation, you do 1 ELISA, 2 ELISA, or 3 ELISA. Now, let me explain that I don't have a slide here. When I say 1 ELISA, it means you can get antibody, antigens, HIV antigens, either from the virus particle itself, or it can be from recombinant DNA, or you can get polypeptides. So there are 3 sources from where you can get HIV antigen. So what you do in this test is you do 1 test using a virus particle. If that is positive, then you repeat another test by using the recombinant DNA. If that is positive, you do the 3rd test using peptides. So you do all 3 tests. Depending on your clinical epidemiology, you do this. In a blood bank, you do not want any contaminated blood, doubtful contaminated blood to be given. So you do 1 ELISA test, and if it is positive, you discard the blood. But if the person is symptomatic, then you do tests. If it is asymptomatic, you do 3 tests. So only when 3 tests are done will the test be declared as positive. And if you work in, if you have seen any government ITC-TC centers, they will write the tests. What is what is the kit that has been used, the number of the kit, and the test that becomes positive. In private practice, very often, most of the labs will do only 1 test and declare the test as positive. So as private family practitioners, you must be careful that the lab has done 3 tests before you declare a person as having HIV disease, because it is like telling the person, declaring a death sentence on that person, because he has to change his life. So you have to be 100% sure. Now, at present, we do not recommend doing Western blot tests, okay, because of cost and considerations that are there. But there are a small percentage of patients where the tests are negative, indeterminate. That is, 1 test becomes positive, another test becomes negative. Then you may resort to doing Western blot tests. So for diagnosis, you need 3 ELISAs before you declare a person as HIV positive. Next slide, please. Now, when we talk about, this is just, Priyanka spoke about it. Remember, conditions that warrant HIV testing can be clinical. It can be because of autoimmune diseases like ITP, Guillain-Barré syndrome, psoriasis, Graves' disease, or it can be opportunistic infections like the oral thrush, herpes zoster, pneumonias in the young, tuberculosis, or it can be people receiving treatment for hepatitis and tuberculosis. They can have co-infections, so you need to test for HIV. It may be behavioral, especially sex partner or patient who is HIV positive, heterosexuals who themselves or separate partners who are there, maybe homemakers, maybe travelers, migrants, sex workers, men having sex with men, and intravenous drug users. Next set of, next slide, please. Yes, here we have another one case. Mr. K is positive and on ART, comes with his wife, Mrs. R, to you with a request that they have decided to have a child by natural means. How can you help them? Now, the couple are there. One of the husband is positive, wife is negative. They want to have a child. Obviously, using a condom, they cannot have a child. Okay, without a condom, they should have sex if they have to have by natural means. How can we help them? Okay, that's a good way of thinking, smart thinking. Okay, one is, if the husband is negative, then you live in as U equals U, so you do not give them they can have a child, one possibility. Any other possibilities? Huh? Pardon? Okay, he says artificial insemination. But then the sperms of the husband seminal fluid will contain HIV virus. Still, that is not going to solve the problem, no? One of the things that people used to do is do sperm washing so that you can remove the virus. And the second thing is in vitro fertilization, doing IVF. Okay, so these are all methods, or the last resort would be to adopt a child. But now with antiretroviral therapy, people can still have normal sex and have normal babies. What I'm going to talk now is pre-exposure prophylaxis. That is, before they are exposed to sex, we are protecting them. And usually the way I do is, next slide, please. Next slide, please. When the couples come to me, first thing that I do is check the viral load of the husband, because in this case, we have the husband who is positive. If the husband is positive, viral load is 0, that means his chance of transmitting the infection to the wife becomes 0. The second thing that I ask is check the HIV status of the woman. If she is positive, the problem is not there. But if she is negative, then we have to talk about it. We have to confirm that she is negative. Not only that, we have to check her renal functions, because the drugs that we prescribe may affect the kidney function, may not produce anemia. So you have to check her up for text. The next thing that we do, which I do in my practice, is teach them about for ovulation. You know, in St. John's being a Catholic institution for family planning, we only advocate natural family planning, and we have a department which teaches women how to identify ovulation by basal body temperature, by the vaginal secretions that they have. So I sent these ladies to go and learn how to identify ovulation. And if the patients come to learn, most of them will learn in 2 or 3 cycles and they'll be confident. Once they come with that confident, if they are confident of identifying their ovulation, and I feel that they're confident of following what I do, I put them on post-exposure prophylaxis. I'm sorry, pre-exposure prophylaxis. Next slide, please. And usually they start their pre-exposure prophylaxis on the day of ovulation. 24 hours later, they have the sex, and if the patient and continue it for 5 days, unprotected sex for 5 days. And if they miss the period, they check for pregnancy test. If the pregnancy test is positive, then we discontinue the drug that we prescribed. And if the person has her periods, then we repeat the medicine for the next cycle. Next slide, please. Now, when we talk about the drugs, the standard regimen that we usually give is tenofovir and amicetrapine, which has been there for 28 days. WHO has come with a new regimen called 2+2+1 regimen. Okay, that is before sex, 24 hours before they take 2 doses, 2 hours before sex, they take 2 doses, and they repeat after sex 1 dose, 24 hours after the last dose before sex, and 48 after the first 2 doses are taken. Okay, so this is a new regimen that has come. I don't have much experience with using this with our patients, but this is one which will reduce toxicity. Okay, and if the person is, if more sex acts take place, a single dose can be continued on daily basis as long as the person continues to have sex with unprotected sex for a long period of time. And among men having sex with men, they have given supplies of 90 days so that they'll have prevention of HIV infection that takes place in them. Next slide, please. And WHO recommends newer drugs like tenofovir can be used, and they talk about dapivirine vaginal ring. You can fit the dapivirine is an antiretroviral drug which is coated in the vaginal ring, which can be used by a woman so that she will not get infected nor infect the male partner with this. This is still experimental. It's not available in our country. Next slide, please. And we need to check hemoglobin, serum creatinine after 1 month of completion of pre-exposure prophylaxis. HIV testing before initiation, 1 month of pre-exposure prophylaxis, you need that. And if the patients are taking TDF containing or whole prep, it's safe during pregnancy and breastfeeding. So we can help these patients even with post-exposure prophylaxis. And as general family practitioners, we need to know about this because patients may come and ask us for guidance. You cannot always be sending them to ERT centers and other places. Next slide, please. Now, when we talk about counseling, we should address the implications of HIV diagnosis, natural history of disease, personal responsibilities, identifications of others at risk, social and financial effects, and initiation of ART. Dr. Priyanka has spoken enough and more about the initiation of ART. I will not talk about it, except reiterate that you should start treatment as early as possible after diagnosis is made. Next slide, please. Now, when you talk about general management, when you're counseling, you talk about nutrition, exercise, treatment of opportunistic infections, prophylaxis for opportunistic infections, empirical treatment, treatment of HIV infections, and lastly, we talk about palliative care and care of the dying. Next slide, please. Now, next slide, please. Okay, when you talk about nutritional, we need to maintain ideal body weight. And the most important thing is you must be food hygiene. So I recommend patients to eat only cooked food because cooking can kill most of the bacteria and the infections rates will come down. The second thing is they need to have high calorie diet or 33 to 44 kilocalories per kg body weight. High protein diet they need to take, and I advise them always to take 1 egg, at least minimum of 1 egg per day. Then you talk about adequate micronutrients with beta carotenes, B12, folic acid, and zinc and selenium. So they need to have fruits and multivitamins and minerals. An important thing is oral hygiene. They need to gargle their mouth after they have meals. So this can prevent infection from occurring. The second thing that you have to always talk about apart from ART is, next slide please, we need is exercise. They need both types of exercises. General isotonic exercises like walking at least 30 minutes per day because it improves in immune function. And the very important thing is, olden days, if you see patients with HIV, they were emaciated. Muscle loss is there. And to prevent muscle loss, you require isometric exercises. So we tell them usually go and have weights at least 3 or 4 times a week for improvement. Next slide, please. Then for protection, we talk about 2 important things, which is there, that is vaccination and de-addiction, especially for tobacco, alcohol, and substance abuse. Remember, tobacco and alcohol can interfere with ERT medications. So we need to talk about de-addictions to patients when you're talking about that. And when we do not think about these vaccinations. They need to be protected against hepatitis B. So they require hepatitis B 3 doses. Then they have to have protection against pneumococcal vaccination with 13 followed by 23. Then you have influenza vaccination that has to be repeated every year. They have to have COVID vaccines. We'll come to it a little later when we are talking about it. Then you have human papilloma virus, which is also a common disease among men having sex with men. We need to be protected with giving vaccination. And now we have zoster vaccination, which can be given, and it costs about 3,500 rupees per dose, and it's difficult to get. So these vaccinations can be used to prevent patients from suffering from opportunistic and other infections in their lifetime. Next slide, please. Then we talk about medical management. We talked about it. Remember, when there is opportunistic infection, the same treatment that you give for non-HIV patients has to be given for HIV positive patients. There is no difference in treatment, except for one disease where we make slight changes, but I won't go into it. And usually as family medicine practitioners, we treat the oral candida, herpes zoster, screen for TB, and we also talk about symptomatic care and palliative care. Next slide, please. Now, there are certain common questions that arise when people start with counseling. One of the, next slide, please. One of the question is, when and where did I get it? This is a common question that people are, they're anxious, they want to know. What answer will you give for this question? Pardon? Yeah, right. Because we cannot pinpoint when they got it, where they got it, and it does not make any difference to their treatment. So we don't talk about it. Okay. Then, and how long is the disease? We do not know. And should I tell my wife? And Dr. Priyanka said, you have to tell the wife of the patient. Okay. Now, what if the father-in-law comes and asks? Or relatives come and ask? Why? Why should the wife know, but the father-in-law should not know? That is the point. The point is the wife is not at is at a risk of getting infected, so she needs protection, so she has to be told. But the father-in-law is not in chance of getting infected, so he need not be told. And remember, this is a very difficult thing for people who are counseling. Like Dr. Priyanka said, as per the national guidelines as well as HIV law, if you do not counsel the person at risk, you will be prosecuted. You can be prosecuted. It only requires one sub-inspector to file a case against you. Negligence, not negligence. There is a section in Indian Penal Code which says deliberating allowing the spread of infectious disease in the community. You can go to jail for 1 year. Okay. Now, when you have this, how to do this? One thing is, most of the patients will never tell their spouses. To begin with, will not tell the spouses. After 2 or 3 counselings, they will tell their spouses. That is about 5 or 10%. Another about 50% of patients will bring their spouse after some time, because they have to also, tell that, and they'll ask the doctor, "Neev heli." So the doctor takes the duty of telling the patients what has to be done. But another 40% of patients, they will never bring their spouses, neither will they tell their spouses. And that is where the problem has arises. And I do not have any ready-made solution how it can be solved. Okay. Okay. Then this question arises, can I have children? Can I play with them? Can I kiss the children? Okay, you can do all your normal activities that you have. Then you can have, can I spread it by eating and talking? That also does not happen. And usually, can I lose my job? Can I get insurance if I have this? In 2017, HIV bill was passed by the parliament. According to that, you cannot discriminate a HIV positive patient from a job unless he's a source of problem for others. Okay, like for example, the court is also very clear on it. There was a sweeper in Mumbai municipality who was penalized, removed from job because he was HIV positive. But they said, no, he has to be retained in the job because it's not a chance of spreading the infection to others. Similarly, there have been army officers who have been removed from areas where they have to fight, and they have been put in areas where they have to do a desk job. And if you're a fighting force, you get more salary than in a desk job. So people have gone to court, and the court has been very clear and said, if you're HIV positive and you're fighting in the field, and often in the fields, if they need blood, they call some of the soldiers and collect the blood and transfuse them. You cannot be useful for that. You may spread infection, so you're not allowed. Okay, so the law is very clear. And recently, the insurance has been there for HIV positive patients. And this is a famous question that people are, can I take alternate medicines? No, Ayurveda, Unani, homeopathy, can I take? What answer will you give? Why no? There is no, I agree with you, there is no evidence. We are trained in allopathic medicine, so we cannot prescribe all that. And we know the allopathic medicine is effective, and we do not know how the Ayurvedic medicines are effective. So you should not do something which has no definite proof that it is effective or not effective. And some of your older people would remember in 1990s, there are hordes of people who are HIV positives would go to Kerala to get medicines. They used to go to other places to get medicines, which was all this alternate systems of medicine, but none of them survived it till they took ART medications. Can I have the next slide, please? Now, when we come to HIV and COVID, this is a pandemic. There are two pandemics, and they have been intersecting. We see the HIV positivity, they have 24% higher risk of getting infection, 78% of higher risk of death. There is no difference in clinical presentation or admission to ICU or mechanical ventilations. That factors that may worsen the prognosis are presence of multimorbidity, older age group, and usually there is poor response to vaccination. Okay, and when we talk about COVID on HIV, what it has done is there has been a decline in testing for HIV patients, and prevention services have come down, STI services have come down, and there has been an increase in unplanned pregnancies and gender-based violence. The effect of anti-HIV drugs in prevention, people have tried to use lopinavir, ritonavir for COVID, has been found to be useless. Okay, next slide, please. Now, when we come to guidelines that it talks about, all that says is the guidelines that I'll say, summarize this whole guidelines, that if the patients have lower CD4 count, they are at a higher risk for severity of COVID infection. And if they have comorbidities like cardiovascular, diabetes, like any other patients, they are at high risk. And opioid use disorder patients are at higher risk. And usually we claim the same things, home care, isolation, quarantine for these patients for treatment. Next slide, please. Now, when we talk to vaccines, next slide. When we talk about it, we have data on HIV patients is only available. What is available in India, I'm not talking about what is available abroad. Covishield, we have is available, and there have been studies which are shown the same strength of immune response in people who are HIV positive and people without HIV. So Covishield protects HIV infected patients. So we would recommend giving Covishield. Whereas for Covaxin, we have no data, whether it is protective or not protective, still because we have no studies which have come out. These two studies which have come out from Covishield are from South Africa. Next slide, please. Then we talk about mRNA vaccines that have been used, and they say the amount of neutralization that produces and lower in patients living with HIV infection. So they're talking about giving them booster dose so that they will be protected against COVID. Next slide, please. Now, when we talk of achievements of ERT, we have PRP, which is effective, early detection is possible, undetectable viral load reduces the spread of HIV, longer lives for those who are with HIV, they live longer. Next slide, please. Now, next 10 minutes, I'm going to talk about future developments that have happened, because there is something which in the 40th year will change how we are going to manage HIV infections. We have a whole lot of new drugs. What I would like to look at is simplification of regimens. As it is, from taking 3 drugs, we have got 3 drugs which are combined into a single pill like Spegra, which you have here. There are viral pills, which is a single tablet that you can do that. There is further modification on this, that you can give 2 drug regimen and you can give injectables. 2 drug regimen is to again use to dolutegravir with a protease inhibitor, and that can suppress HIV infection, reduce the side effects. Next slide, please. We talk about 2 therapies that are common to this thing, which can be long lasting. The one which is available easily all over the world is carbotegravir with repliverin. You give an oral loading dose for 1 month, then you give intramuscular injection for 1 month, then you repeat continuation phase. Every 3rd month, you give them 1 injection. Okay, so that reduces the chances of missing doses. It requires more of follow-up for the patients, but it's shown to bring down HIV infection rate. Then there is another one drug, which is a capsid inhibitor for lenacapavir, which can be given as a intramuscular injection once in 6 months. So there's so by the next 2 years, if I had to talk, I may be talking about lenacapavir as a major way of treating HIV positive patients. Next slide, please. Then we talk about neutralizing antibodies, which are there, which help to eliminate, increasing the rate of virus elimination. They ensure the killing of virus, and because they stimulate the immune response, initiate immune responses, and you should also have combined with multiple antibodies or combination of drugs and antibodies that can be used. Next slide, please. Then when we talk about vaccines, we have preventive vaccines and we have therapeutic vaccines. Till date, we do not have any vaccine which is available to prevent HIV infection. Therapeutic vaccines are vaccines that can be given where already infected people is going on. And usually you have different technologies that we use to stimulate. And this is supposed to bring the better cure rates for patients in HIV infections. Next slide, please. And we talked about it. Next slide, please. And other thing that is coming more in the West as well as in Africa is point of care testing. Just like we do glucometer testing for blood sugars, you can use this point of care testing for diagnosis of HIV, which is a self-testing kit. Okay, but as family practitioners, viral load monitoring can become a point of care testing. So in your clinic, you can test the person's blood, get a report, and you'll be able to monitor the patients better, which is again a point of care testing which has come into use. And so far in India, it has not yet been available, but it's in Africa. It has been supplied to most of the PHCs where this can be done without much of a problem. Next slide, please. Now, other things that I talked about is immunotherapy, gene editing. These are high-flow therapy that will come, and hopefully when this develops, we may be able to target hidden HIV viruses in the brain and in the gut and bring about cure of HIV infection. Next slide, please. And what we are aiming is to reduce the HIV infection so that it becomes manageable. And next slide, please. When we talk about future of challenges that we have is what is happening now is with the onset of COVID, the attention on HIV has disappeared. And as we started, the chairman said, oh, we heard was in 2005. After that, we have not had HIV. So people are becoming complacent because the drugs are available and treatment is been there. And similarly, with activism, which was very, very strong in the beginning, we had transgenders, we had men having sex with men, sex workers who are active. Now, slowly, that activism is going off. And as a result of this, funding for HIV research is also coming now, which again has a problem for us. And what has become is, with the HIV is becoming more and more of marginalized groups, sex workers, transgenders, men who have sex with workers, and it's more common in adolescents, prisoners, and detainees. And even today, criminalization of behavior that can spread HIV has not been reduced. Like we only in the last 1 year, we had the Homosexual Act being removed. We still have this Prevention of Immoral Traffic Act, which penalizes people who have sex with sex workers. These are things that need criminalization that has been reduced. And after 40 years, we still cannot provide basic public health facilities, which is what the WHO and the government is talking about, to provide basic health facilities. And this is where, as family practitioners, HIV becomes important for us. Next slide, please. Now, when we talk about ending HIV, there's a long way to go. What people talk about is we must give universal health coverage to people. And only when there's universal health coverage, which is a human right issue, that we will be able to eradicate HIV infection. And instead of being a silo where only HIV experts treat HIV positive patients, if family practitioners and general physicians can handle HIV, then the disease spread will become less, because people will become more effective in talking about it. And that is why now the national government of India is also trying to spread HIV into primary health centers. And we should have targeted programs, because we know there is high risk population. They have their own culture, they have their own behavior. We need to target our interventions to attack these patients. And we also talk about vulnerability, climate change, migration, all of them help in helping to spread the HIV infection, and we need to be aware of that. And remember, lastly, when you ensure human rights for all, we'll be able to eradicate HIV infection. Thank you. This is the last thing. Next slide, please. Okay. If there are any questions, I'm ready to answer.
Any questions from the audience? I think you have a question.
Yeah. So, during the pre-exposure prophylaxis in women who want to get pregnant, since you start the pre-exposure prophylaxis 2 days before the ovulation, and
Not 2 days, on the day of ovulation they take.
on the day,
And 24 hours later they have sex.
okay, 24 hours later they have it, and then they can
5 days of unprotected sex. Then after that, again, you use condom.
okay, and we know whether conceive or not only the
See, because the treatment is for 28 days. Usually ovulation takes place 14 days before the next menstrual cycle. So if she's missed a period, then you know she's pregnant.
So that means that is in case it's a patient is conceived. So patient is on the
Yes, patient is on these medicines, but this for suppression of HIV. But these medicines do not affect the fetus.
So that's the question.
Because Dr. Priyanka made a statement, dolutegravir is supposed to produce neural tube defects. And if you give them folic acid, even the neural tube defects will disappear in these patients.
It's advisable to give folic acid.
Yeah, that is usual antenatal testing that we give them.
And of course, we assume the treatment is for life, right? So is there any changes there for HIV?
As of today, it is for life. Maybe it will change in another 5 years' time. As of today, it is lifelong treatment. The reason why it is lifelong is because we have reservoirs. There is viruses settle down in the brain and in the microglia and in the gut marl lymphocytes. And you give this there, whenever this breaks and comes out, you have the antiretroviral medication that will prevent the infection from occurring. That's why it is lifelong. According to mathematical modeling, it takes 25 years for these virus reservoirs to disappear. Okay, and now what they are trying to do is they want to kick this virus so that they become active earlier and the ART will act. But one of the medicines that they used 5 years ago has been found to be a failure. That's why I did not talk about it.
Any other questions?
Person has a needle stick injury and was put on prophylaxis. On 10th day, patient developed fever, diarrhea, was stopped here, and it led systematic. What is the next course?
Wait
It
for
is there on the screen, sir. Person has a needle stick injury and was put on prophylaxis. On
Yeah.
10-day patient developed fever. I think that's rashes, diarrhea and vomiting. So stopped ART prophylaxis and treated symptomatically. What is the next course of action?
next course
Dr.
of
Nagaraj?
action is you need to identify whether this person has seroconverted. So 2 weeks after the needle stick injury, 2 weeks after the injury, you need to repeat the HIV ELISA test. If the test is positive, then you know that he has got an acute HIV infection and he needs to be started on ART immediately. If the test is negative, you repeat the HIV test after 4 weeks to see whether he is really negative, not a false negative that you have got on this patient.
Thank you. So we can conclude this session and thank you. One more question.
Such needle injuries will cause the positive antibody for
Sir, this question has been answered long ago in 2000. Okay, the chances of getting infected by a needle stick injury is 0.003, 0.03% of needle stick injuries. So if you have 300 needle stick injuries, you will get infected. In 2000, why I said it answered in 2000, in American CDC had a registry for needle stick injuries. And after 2000, when they found this statistics came, they stopped the needle stick injuries. And we have had every year, we get about 40 to 50 needle sticks injuries in St. John's. Until today, last 20 years, we have not had a positive person coming.
Is it advisable to use gloves and give it to double gloves and give a injection to a patient or just?
No, see, universal precaution says treat everybody as HIV positive, viral infections. Whether you wear 1 glove or 2 gloves, it's better to wear gloves if you are doing a procedure on patients.
Or safer.
Safer.
Okay. So thank you very much, Dr. Ravindran. Now I request Dr. Harish, President of FPA, to come on the dais and honor Dr. Ravindran. Thank you, sir. Thank you, Harish. Now, not the last but the least, we have a vote of thanks. I request Dr. Jagdish Antin to come and give the vote of thanks. And before that, we would like to honor our MCure marketing people, Mr. Sabir and Anusha. Please come on the dais. Come. Please come. Anusha and Sabir, please. Thank you very much for coordinating with us and conducting the CM. Thank you very much. Thank you. Dr. Jagdish, please give the vote of thanks.
Dear friends, good evening. On behalf of FPA, I would like to thank all the speakers and all the attendees and all those doctors who are attending this online. We're all grateful to you for having attended. Thank you again.
Now we shall break up for cocktails and dinner. Thank you very much.
I know it was very nice. Informative and good.